is Ramtin Mehraram from Leuven. I'm talking about brain connectomics and acquired disorders.
All right. Good afternoon, everybody. It's very much happy for having the opportunity to talk to you, discuss with you a bit about some research I've been involved in recently, and that is application of connectomics methodologies for investigation of dementia and post-stroke aphasia. So my background is biomedical engineering, so I obtained a bachelor and a master, and towards the end of my master's, as well as a bit later after that, I gained some expertise in EEG signal processing, and that is what we're going to talk about today. But it's only at the PhD at Newcastle University when I finally started the first project on EEG-based connectomics on dementia. And at the postdoc at Leuven, I worked on EEG-based connectomics and post-stroke aphasia. And the first thing we're going to talk about is the dementia part. So let's talk about dementia. So what is dementia? So dementia is not a disease. Dementia is a condition, is a syndrome that can be caused by different diseases. So that is what a typical healthy brain tissue looks like. So normally a healthy brain tissue, our brain in general, contains thousands of proteins, and that's totally fine. The problem is when some of these proteins may shape in tangles and plaques. And when this happens, we may get Alzheimer's disease, which unfortunately is quite common. And when it degenerates, it can get to Alzheimer's disease dementia. However, there's another type of proteins which can shape in bodies known as Lewy bodies, after the scientists had observed these bodies first. And this is a Lewy body pathology, Lewy body disease. And this can degenerate in either dementia with Lewy bodies or Parkinson's disease dementia. And these two are known as Lewy body dementia. Now, what is the point? These Lewy body dementias have a similar pathology, but from the perspective of the symptoms, there is an important difference. So Parkinson's disease dementia first develops Parkinsonian symptoms, so tremor, rigidity, and later on, cognitive issues. But for DLB, it's the all the way around. You first have the cognitive issues. And as you may guess, at the early stages, this can cause issues when it comes to diagnosing it against Alzheimer's disease dementia, because the symptoms might be very similar. And so what can help here are biomarkers. And this is where my research jumps in. So this study is about an exploratory study on the functional connectomics, the functional connectome, and how it is affected, if it is affected, in dementia and the different types of dementia, and whether this can be used to distinguish between dementia with Lewy bodies and Alzheimer's disease dementia. So this is the cohort we used, and what is important here to notice is first that the subjects were age matched, because it is known that age can have an effect on the connectome, the functional connectome, but also between the dementia groups, there were no differences in cognition. So we really focused just on the pathology, underlying pathology behind this. And the paradigm, experimental paradigm, was a resting state. So the simplest possible. So there were no potential difficulties that patients might have encountered while recording the EEG. So just 2 minutes resting state or something like that. But first, what is connectivity here? So as we discussed about during this workshop in these 3 days, connectivity can either be structural, so we have actual white matter connecting neurons, or functional. And EEG, of course, will be functional. But how to define functional connectivity in EEG? One may say, okay, I'm just going to take the signals from the electrodes and compute correlation. Yes or no? That's definitely an index of some sort of relation between the signals, but I would say we can go with more fine-tuned approach and look at synchronization between signals. And you will see now why. So the simplest way to look at synchronization is phase coherence. So if you take the phase from two signals, this phase stays quite steady in the two signals, so the difference is quite steady, you can get higher synchronization, hence high connectivity. However, the problem with EEG signals is that a common issue is volume conduction. So what may happen, and that's very much true for electrodes which are close to each other, is that the electrodes might be bridging. So what we're actually observing is not the electrodes recording different signals, but recording the same signals. If you compute connectivity between these two signals, which is actually just one, you get a false positive because you get full connectivity, whilst that's not the case. So how to handle this? Well, Stam and colleagues in 2007 proposed an alternative to phase coherence, which is called phase lag index. By definition here, using the signal function, when the phase difference is 0, then connectivity is 0. So we're going to get rid of all zero lag connectivity. So volume conduction is a sorted issue. But is it really? To some extent, because this is the ideal case in which volume conduction causes zero lag. But there might still be noisy conducting sources in there, and those can cause almost zero lag connectivity. So close to 0, but not 0, and it's still not real connectivity. So there has been an improvement of this measure in 2011 called weighted phase lag index. As the name says, you're going to weight the phase lag index by some measure, which is the imaginary part of the cross spectrum between the signals. And this measure is linked, is very much associated with the phase difference itself. So what you're going to do here is to weight down those connections which arises from phase differences close to 0. So in this way, you're kind of trying to even more disentangle this volume conduction issue. And this is the measure we went for. But is it the perfect measure? Of course not. Your research is always about rational compromises, trying to, based on the hypothesis and the research question, choose the most suited methodologies. Because one problem here is that we're getting rid of real zero lag connectivity, because I didn't say that it doesn't exist. It is there. And by doing this, we're going to remove this. But this was a matter of decision, the choices, research choices, and we went for this. So if we perform a first analysis to get an overview of what's happening in the connectome, so we look just at average connectivity, we can see that, of course, there is a difference between controls and dementia groups. And this difference is mostly in the alpha band. But what is interesting to us is between Alzheimer's disease and dementia with Lewy bodies, and that appears to be in the beta band. We can even explore further. And as you remember from the talk on the first day from Markus Kaiser, who, by the way, was my PhD supervisor, the length of the connections is important because not all the connections are normally are affected at the same time. There might be some dependence on the length of the connections. And so what we did here was to classify the connections based on their Euclidean length and to see whether there's any effect of the length of the connection on the differences between groups. And we found that in the difference between dementia and controls, it seems that the long connections are the most affected. But when it comes to DLB versus PDD, DLB versus AD, it seems to be quite all type of connection to be affected. And so this gives us more details on what is going on there. But of course, we're not still happy because we have plenty of tools in Connectomics to get some information. And most importantly, here, we are still lacking some topographical information. Like how are these differences distributed across the network? So one could say, okay, I'm not gonna take connection by connection. I'm just gonna perform some t-test and see which connections are actually different between groups. But now imagine having a 256 times 256 EEG cap and having to make a comparison between all these connections. It's statistically meaningless. And also you cannot control for multiple comparisons. So either you go for average as we did here, or there's another way, which is cluster-based approach. So there's a method called network-based statistics. And that's a cluster-based, as any cluster-based is based on permutations, computation of the null distribution. And by doing this, you're gonna find those connections which are so you're not just finding single connections, but you're finding network components, so connected clusters that as such are rejecting the null hypothesis. And by doing this, you're able to control for the family-wise error rate. And when you do this, you find that that is how the difference between DLB and AD is distributed in the connectome. So it's mostly left hemispheric differences frontal posterior, which somehow resembles also what has been found in the literature with other approaches, and also mostly occipitotemporal on the right hemisphere, and also temporal right hemisphere. So in this way, you have a better, more detailed overview of how the connectome is affected in terms of connectivity strength. But connectivity strength is not all we want to look at. We have also graph theory. And graph theory can give us some information on the geometry of our connectome, our graph. But the thing is, before being able to perform graph theory, you need to have a graph. And if you take just the connectivity matrix as it comes out from computing connectivity between electrodes, it's just a fully connected matrix. And there's not much you can do from that. So you need to define some strategies to actually get a meaningful graph, something that is of interest. And in the literature, that has been proposed in many ways, and it's still ongoing debate about that. So there's still not an official, recognized way to do that. But the easiest way is to apply a threshold. So you say, okay, I'm going to set this value. All the connections below that value, I'm not interested in those. Everything above, I'll preserve that. And you can do it in an absolute way, so you adjust a certain number. But as you can guess, it sounds arbitrary and also makes it difficult to perform statistics and compare between graphs. So an alternative, which is what we did here, is proportional threshold. So instead of choosing one value, you choose a certain percentage of connections. So for instance, I say, okay, I want to preserve the 20% of the strongest connection, the 30%, the 40%. To me, that is the meaningful part. And everything else goes to zero. And that by doing that, you're preserving the network density. So you choose a certain density and you make it comparable you can make networks comparable and perform meaningful statistics. And that's fantastic. You remove the bad connections, you preserve the good ones. But then another question, what to do with the good ones? Should we just preserve the information about good or bad, or should we keep the weights? That's also a lot of debate on that. So I've seen there are a lot of research and models showing that preserving the weights is useless. It doesn't give any additional information, that instead binarizing is more useful, whatever. But here we had a clear hypothesis that we wanted to explore. Our hypothesis here was that weighted measures are better in the sense that they help to reduce the dependence of the graph measures on the network density, because that's a known issue, the fact that when you apply the threshold, depending on where you apply the threshold, the graph measure can be affected. And we thought that by using weighted graph measures, this dependence is somehow attenuated, reduced. I wanted to prove that. So to do that, what we did, we took a graph measure, in this case, path length, but can be done also with the clustering coefficient. And we have the binary case and the weighted case. And we took from 0 to 60% thresholding values, and we fitted the curve, the power law curve, and we got the corresponding equations. And of course, we have some values for those equations. So the question we want to answer is about the dependence on the network density. And the dependence here is the slope of these curves. And the slope, mathematically speaking, is the first derivative. So we just compute the first derivative. And our hypothesis is actually the derivative lower in weighted compared to binary measures. And so if you replace all the coefficients into those equations, you test that, you find that we were right. So for basically all the thresholding values, the slope, as you can also be seen visually, if you look at the values there, is way lower in weighted measure compared to binary. So it's more robust. The outcome of the analysis is more robust and more reliable. So based on this, we decided to move on to perform the rest of the analysis using weighted graph measures. And now I'm not going to show to you all the graph measures, but this is just to give you a brief idea. I showed you the path length and the small worldness. In general, what we're finding here is that dementia with Lewy bodies versus Alzheimer's disease, which is what we're mostly interested in, somehow the differences are resembling what emerged from the connectivity differences. So the beta band seems to be the one that is most involved across all graph measures. And what is interesting, and the most interesting part, are beside the path length that shows a lower segregation a higher segregation, lower integration in dementia with Lewy bodies, which can be meaningful. But what is interesting, maybe you've noticed that the small worldness is higher in dementia with Lewy bodies. And that's kind of I don't know, could appear as a weird thing because small word is normally an index of efficiency of a network. So social networks are small word. And a small word network is a network that has higher clustering, at the same time, high integration. So it's a well efficiently organized network. So what is the meaning of this? So to understand this, we performed a further analysis, graph related, which is called targeted node attack. This analysis, it explores an assumption about, and a characteristic of this type of networks, which is the robustness to external attack. So small word networks, since they are quite distributed, are more resistant to targeted attack to highly connected nodes as compared to, for instance, scale-free networks, where there are fewer nodes highly connected. And so we wanted to test this to see whether actually DLB emerged to be more small word than other groups. And we performed this targeted node attack. And what happens is that we progressively removed node by node, and as more nodes were removed, and we compute the path length, and this is a typical trend you observe. You observe an increasing path length until all the shortcuts are removed, and then a decrease. That's a pattern that emerges when you perform this type of approach. And what is interesting here is that you can see there's a later peak in DLB compared to AD. And the later peak means more small word, more resistant network, so more small word or random network compared to scale-free. And so this further confirms the fact that DLB is more small word. But also this kind of analysis falls within a debate that, again, also this one is very ongoing. That is, how is actually our brain? Is it small word? Is it scale-free? And it's still kind of, as Marcus said the first day, it doesn't have to be one of them because the brain can have a combination of different types of organization. But still, it's interesting to kind of speculate on this. And most interestingly, like clinically relevant, is the fact that these measures are good to discriminate between the groups. So if you put in a classifier, you get a very high accuracy. You can distinguish DLB from Alzheimer's disease. And so this makes the whole thing quite useful. And so what we showed with this is that Connectomics works for this. We can use it for distinguishing DLB from AD. And as a side analysis, we should use weighted graphs rather than binary graphs. And I hope this was convincing enough. But now we can even do something a bit more exciting. So moving to something a bit more specific, not just DLB, AD, but there's a very specific symptom of DLB, which is very much of interest in research because it's something that in Alzheimer's disease is more rare than DLB. So it is used, it's a core clinical feature of DLB. It is used in clinics as an indicator of the presence of that condition. And that is visual hallucination. So this study, which doesn't appear, I don't know, it's there, but it's not here, there it is. This study was, again, an investigation of the connectome, but this time was functional and structural. And also we investigated how is the coupling between the two networks in Lewy body dementia patients with and without hallucinations to see what is actual correlate of this specific symptom. So what are visual hallucinations? Visual hallucinations, as the name says, are seeing things that are not there. And that's, as I said, it's a very common symptom. 80% of patients with DLB experience visual hallucinations. Now, what is interesting to us is how are these generated in the brain? And this has been, there are different ideas that have been proposed through computational models. And so we can take a quick look at that. So this is our brain, let's suppose. We have eyes and a visual stimulus that we perceive with the eyes. So what happens here is that, first of all, this visual stimulus is projected all the way back to the occipital cortex, going through the lateral geniculate nuclei of the thalamus. Now from here, there is a bifurcation of the road. So we have a very fast path projection from the occipital cortex all the way to the prefrontal cortex. And this very fast projection is a transfer of a low quality, kind of a low frequency version of the signal. And the purpose of this is to see, because the brain is lazy, is to see whether we already saw that object. We already know that. And what the prefrontal cortex does especially the orbitofrontal cortex, is to retrieve information from the amygdala, from the hippocampus, and to see whether we already saw that, we know that, so we don't need to activate anything like to react actively to that stimulus. We can just retrieve it from our brain. And what happens then? This template is sent back to the inferior temporal cortex. Slightly later, a matter of milliseconds, there's a high-quality version of the signal, which is sent from the occipital cortex already to the inferior temporal cortex. And here is where the matching happens and the image generation happens. So what the computational models of visual hallucinations in DLB propose is that this matching is damaged. There must be a problem there, possibly both top-down and bottom-up streams. And with the work we're talking about now that I'm going to show you, we wanted to see whether we could find an empirical evidence of this, and that this somehow emerged into from real data. And so the cohort here is a subsample of the other cohort, because we need the DTI data to perform a structural connectivity, but also in this case, we also performed source localization. So we didn't just limit the analysis to the sensor domain, just the nodes were not the electrodes anymore, but this time we're actual cortical regions based on a parcellation that in this case was the Destrier atlas of 148 regions. And so we're working on a source domain here. And the source localization was performed using real MRI, the individual T1 data. So that's why it's a subsample. We couldn't use all of them because not all participants had the MRI data available. Similar to the other analysis, connectivity was computed with the weighted phase lag index, but we focus on the alpha band here because the alpha band is the one that is mostly related to visual processing, but also it is known from other research that has, it reflects the pathology of DLB in other type of EEG-related biomarkers, which we're not talking about here, but has an important role there. Database statistics again. At this time, we had the structural part, so probabilistic cryptography, in which we included the thalamus because of its role in the generation of EEG signals. The nucleus basalis of Maynard, which is the main source of the cholinergic system in the brain, because the cholinergic system is known to have an important role in the LBD pathology. So, and this emerges mostly from medication, like it is shown that when you apply, provide cholinergic medication, EEG values go towards more normal values, and also symptoms are attenuated. But until that time at least, there was not very much clear evidence of the correlation between the cholinergic system, the cholinergic anatomy, and the functional processing in the brain. And that's why we included this into this analysis. And then we saw how is the coupling between the two. So this is what comes out from network-based statistics. So the graph that is different, significantly different between the two groups, between the non-hallucinating and hallucinating patients. And what is interesting here, as you can see, is that the affected component, which includes some connectivity between prefrontal cortex, inferior temporal cortex, and more occipital region, and between inferior temporal occipital regions, is very much resembles the models I showed to you at the beginning. So it's very much, what appears here to be is that it's actually the visual ventral network to be affected in hallucinating patients. So it kind of confirms what the computational models have modeled, that have proposed. And it is very fascinating. When it comes to structural, first of all, so the structural analysis we perform here, this is an important detail. It was not just probabilistic spectrography between cortical regions or whatever. As I said, we included the nucleus basalis of Maynard, the thalamus, and from the cortex, only those regions which appear to be part of the network-based statistic component. So only those regions which were functionally affected in hallucinating patients. So it's basically the functional analysis driving the structural analysis. This is the approach that we follow here. And what we found here is that indeed what are supposedly the cholinergic projections toward the functionally affected cortical regions are damaged. So hallucinating patients show damaged streamlines. I mean, it's not directional, but we can assume that it's from the NBM, nucleus mosaics of Maynard's toward the cortex. And when we look at the coupling between the two, between functional and structural connectivity, so functional average within the NBS component, structural is number of streamlines. What is interesting is that we're finding that in non-hallucinating patients, there is a correlation between the two. But in hallucinating patients, this correlation is broken, it's disrupted. So one hypothesis here could be that in non-hallucinating patients, although there is an LBD pathology, to some extent, a physiological correlation between the two is preserved, between the functional and structural network. But when it comes to hallucinating patients, this is completely gone. This is gone. This is broken. And so this work also proves that connectomics can reveal stuff about this specific symptom, and specifically is the visual ventral network to be affected. And not just that, also the coupling between structural and functional is disrupted. And what is now what the direction that the research is taking now, which I'm not involved in anymore, is looking at whether this type of biomarkers can be used at the early stages of the pathology, because that's where you really want to detect this. If you can use this type of biological clue, like physiological clues at the early stages, at a mild cognitive impairment stage, that will be really useful to actually assess in time the pathology and provide the correct treatment and try to slow it down, to slow the pathology down. And this was about dementia. Now let's move to the other part so we can prove that also aphasia can be a good application field for connectomics. So specifically, this is post-stroke aphasia. So this is a study, it's a peer-reviewed, it's preprint. And this study, what we try to do is to see how, if there is a functional network associated with the way our brain processes the speech, processes the perceived language. And it's not just some areas of the brain responding to speech, but if there is an actual organization, network organization. So we as humans speak every day, right? This is our main way to communicate, to express our feelings, and so on. But what can happen is that one of a sudden, it can happen that unfortunately, we can get a stroke. And if the stroke affects our language regions, then this can translate into aphasia, which is a condition in which we have an impaired communication, impaired speech perception, impaired comprehension and reading, and so on, depending on the severity of it. So what we can do here, we can look at EEG. So this is a study that a former colleague of mine has led. In this analysis, we showed that a response to speech, which is called neural tracking, is something similar to event-related potentials, but it's not based on trials. It's based on linear and nonlinear models that can detect the association between the EEG signal and, in this case, the envelope of the speech signal. And this response to stimulus is lowered in aphasia compared to healthy control. At the same time, there's a study before this that I led and still under review. It's been 1 year so far. It is under review, first round of reviewers, long-lived scientific reports, that showed that in the theta band, there's higher connectivity in aphasia compared to healthy control. And this is interesting because the pattern that emerged from network-based statistics involves the very left hemisphere, is likely to be language and auditory regions. So it's quite meaningful. And this hyperconnectivity, of course, the best way to interpret this is perhaps some compensatory effect. And the study that I'm going to talk now is combining the two. Because in that case, I was just looking at the EEG time series. But instead, let's look at these specific responses from each electrode, and let's see if there is any synchronization between these responses, if these responses occur in a synchronized manner, and they're not just isolated in different brain regions. So what we did was to compute the neural tracking, that was the first step, And we only focused on those 3 frequency bands because those are known in language neuroscience to reflect the important physiological processes related to language processing. And then we perform some connectivity because for each electrode at that point, we have a neural tracking signal instead of time series. And we perform some connectomics, so network-based statistics, graph theory, and also correlation with some behavioral score to see whether this connectomics can also provide some information on the severity of the condition. So what emerged from the network-based statistics is a reduced component in the low gamma band in the aphasia group. And this component is mostly localized. The highest effect is on the left hemisphere, where most of the lesions are. So it's quite meaningful, I would say. And the gamma band in general is known to be associated with the high speed rate of speech, the processing of high speed information, so like the phonemes and stuff like that. Graph theory and overall, if you look at the overall measure, like here reported modularity, small wordness, but what emerged from here is an overall segregation of the network when you have aphasia. So the network is more disrupted. And again, interestingly, there's higher small wordness in aphasia compared to controls. And if you look at whether there's a correlation between behavioral, in this case, a naming test. So the NBT is the Netherlands Benoemd test when they have to name a certain number of words in a certain amount of time. And the correlation between connectivity and that test is a positive correlation. So we see that this comes from network-based statistics when the hypothesis, in this case, it's a correlation. Network-based statistics can be used also for correlations, not just for t-tests. And we can find one component, which only includes one connection, which is associated with a positive correlation between severity of the disease and connectivity strength. Now, it's just one connection, which makes it suspicious, but I believe it's because of the ceiling effect that we have with the behavioral score. But it doesn't mean that it's wrong because the trend is kind of there. And what is interesting is that there's another study from a former colleague of mine where we analyzed the distribution of the lesion with a lesion overlap map. And as you can see, there's a quite nice overlap between the two. So where mostly the lesion is where this thing emerges. So we found that, first of all, neural tracking is a network phenomenon. So it's not just some regions responding to speech, but the overall brain in a network manner responds to the speech stimulus. And this network is hampered, is weakened in aphasia. So there is the organization, the physiological organization of this response is somehow broken down. And connectivity measures can give us also information on the severity of the condition. But now there's a question that remains unanswered, which is it possible that what we're observing here is just an effect of the lesion? Because the lesion, of course, causes some anatomical alterations and as a consequence, physiological alterations. So perhaps we're just finding some volume conductions happening there due to the lesion. And the answer again here is source localization that can help to, if the lesion is correctly modeled, then all the results can be more robust and more believable. But unfortunately, by the time I finished my postdoc, I didn't have the time to finalize this part of the study and left as a legacy to the research group. So for the first part of what I presented, I have to thank the funders and my research group the research group I was part of at Newcastle University. And for the second part is at KU Leuven. And now I am unemployed. Like I'm very much open to other opportunities. So if you know, if yourself, anyone is happy to welcome a profile like mine, or you know someone who is interested in someone with my expertise, I'm very much happy to embrace new opportunities. And I thank you for your interest, for your attention, and I'm very much open for questions. This is my happy dog.
Any questions or job offers for Ramtin?
No job offer, but I have a method question.
Yes.
For the NBS, what kind of component forming threshold did you use and how did you decide? Well,
Which kind of, sorry?
Component forming threshold did you
Yeah.
choose for NDS? And how
So-
did you choose?
Yeah, so normally what I did was selecting a range of thresholds. So like I went through, so if you see, yeah, then let's see, for instance, here, you see the colors are a bit different. So like what I did was go for a range of thresholds. So the more permissive thresholds, so more distributed effect are the brighter. And then when you put the stricter thresholds, so more local effect are the darker lines. So I did it like that, so you can have an overall view of what is happening there.
Was it also the case for when you only had one?
In that case, I don't remember, but maybe that connection emerged from 2 or 3 values or something like that. But yeah, I don't remember exactly which value was it, because the value actually I don't think matters that much. But it is likely there was few values that I tried, because that's a weak point of this method, that is arbitrary, the threshold. That's why the best approach is to choose a range. And for that case, also, I think I'm sure I tested a bunch of values, but I don't remember if that connection emerged just from one value or a range of those.
Did you test if this one connection also appears if you just do standard multivariate testing?
Standard what, sorry?
Like just standard multivariate testing?
No, because I'm just relying on this method.
I wonder, is there some about the perception without object, the visual hallucinations? Is there some connectomic fingerprint to differentiate between different diagnoses, which like Lewy body dementia or schizophrenia or drugs, when psychosis by drugs, or the different? Is there some
The types of hallucination, you mean?
yeah,
Depending on from which pathology they come
yeah,
from.
depending
That's interesting,
on
but not that I'm aware. Like I didn't see any.
or is it studied?
I don't think so. Not as far as because I mean it's been some time I haven't worked on this topic because then I moved to the postdoc work on aphasia. I don't know if anything came out like that, but till the time I was working on that,
It would
I
be
was not
interesting
aware.
to analyze.
Yeah, it would be, because then the problem is it's already difficult to disentangle within because there's so many factors in there. So you cannot, you cannot in this way you make an assumption that the visual hallucination is one thing, but it can be really also within hallucinations. You have complex hallucinations, simple hallucinations. It's very difficult to put them together, pathologies, and then that would be interesting to explore. Maybe if someone is brave enough to go
same
to
areas or not, or different areas interacting to provoke the same symptoms, or
indeed, absolutely.
I have a question. So in the study where you combine DTI and EEG, did you have also available fMRI data so that you can compare? Maybe?
No, I did. No, I mean the fMRI data was there, but I didn't look at that. I just focused on because it's out of my expertise, the fMRI. I just focused on EEG and